Professor Efthimiou, you have just moderated a session on auto-inflammatory syndromes. What were the key topics and messages of the session?
Well, I think it was a very comprehensive overview of all the autoinflammatory syndromes, and every year we seem to have 3 or 4 new ones described. So it's an exciting time, but also it's important to educate physicians about the different mechanisms for the autoinflammatory diseases, the clinical presentation, and the therapeutic options.
Your own research focuses on adult onset Still's disease. What led you to this focus, and what are the main characteristics of the disease?
Well, the adult onset Still's disease is often a diagnostic dilemma. These patients are challenging. The disease never really reads the textbook, but it can be very variable and protean. And I thought it was a great example of non-autoimmune diseases that can be chronic, devastating, and there was a need to investigate it further and look for better targeted treatments.
How can AOSD be diagnosed, and what are the treatment options available at the moment?
Right, so the diagnosis is clinical. There's not a single diagnostic test that can help us make the diagnosis, but it's more the clinical presentation and at the same time following diagnostic or classification criteria, excluding other common diseases, including cancer, infection, and other rheumatologic disease that can have a very similar presentation, and then making the diagnosis and treating the patient, because often they're very much affected by this disease.
AOSD is classified as a rare disease. What are the incidence rates, and how often does it go undiagnosed?
Well, it is a rare disease. The new cases are 0.16 or to 0.4 per 100,000 people of population, but it's not uncommon that a physician may not see it in their lifetime, so they need to be prepared and ready to diagnose that. In my opinion, it can often go undiagnosed, or there may be important delays in its diagnosis from weeks to months while the patient is very sick, cannot work, it can even be bedbound. That's why we need to look more into the pathogenesis, find the mechanisms that drive that, and possibly come with better diagnostic tests.
You just mentioned the patient might not be able to work, but as I understand, the age at onset is mostly before the 20s.
Well, most patients are diagnosed before the age of 35, but we know that it's a chronic disease, and it can have distinct bouts called flares. And we recently presented, as of yesterday, a presentation where we looked at patients that are hospitalized in the United States. We found that it's close to 1,500 cases per year, and many times the patients that are hospitalized are in their 50s because they may be older, they may have other comorbidities, and it's important to not think of it solely as a young person's disease, but more of a chronic disease that can come and go or have flares and may go into remission in between.
Coming back to the ACR, could you just summarize your personal Congress highlights of this year's event?
Well, I think it was a very important meeting. We found a lot about new treatments, even brand new mechanism of action with that can change the therapeutic algorithm, and that's for rheumatoid arthritis, very important spondyloarthropathies, systemic lupus, and of course, let's not forget the autoinflammatory diseases, where we have targeted treatments and a deeper understanding of its pathogenesis.
As a rheumatologist, what do you believe will be the next breakthroughs of the field?
Well, I think precision medicine is what's been discussed the most. We have a plethora of information about genetics, so if we're able to blend our knowledge of genetics, immunopathogenesis, and targeted treatments, I think we'll come up with better strategies and hopefully even better medications.
Thank you very much for your time.
Thank you. It was a pleasure.